up here. I know I've met most of you, but my name's Richard Bradbury, and I'm the Development Director for Jewish Federation. So thank you all for being here today. I am introducing today. Yes, yes, because Adi and yes, and Amanda are on the camera, which I'd rather do this than work the camera. So I'd like to welcome you all here today to the JCC, and our guest today, and I've had the pleasure for the last half hour of talking with Michael Stanislaw, who is our speaker today, and he is here to talk about his experiences with the book that he has written and everything that has happened prior to and up until probably yesterday.
That's correct.
That is happening with Michael and his challenges, and I think we've all experienced these with our medical community and the medical systems. So Michael is going to talk about his experiences and his book today. But I would like, since he took the time to write a bio, I would like to read that for you. So Michael Stanislaw is a former graphic designer for over 37 years and a lifelong advocate for personal well-being and maintaining an active, robust lifestyle. He shared with me that he is a runner, and that is one of his challenges. He doesn't get to run that much anymore. So through his own deeply personal struggles with a rare and complex disease, Michael became an accidental expert in self-advocacy, which is something I think we all understand, that we have to be our own advocates within the medical community anymore. It's becoming too Byzantine. His persistent research and navigating a medical system that's not designed for those who don't fit the textbook diagnoses. So he shares his story to empower others lost in the diagnostic wilderness, guiding you towards reclaiming your own voice and offering a testament to the quiet strength found in fighting for an atypical diagnosis when clarity seems impossible. So just a little bit that we were talking, I think you will find Michael's experiences relevant and unfortunately rather pervasive. So across the span of every population. So I'm going to turn it over, and please welcome our guest, Michael Stanislaw. Thank you, Michael.
Thank you. Thank you so much. My old nemesis is public speaking, so bear with me a little bit. So I thought I'd start out with an icebreaker. Show of hands, how many of you here today have been to the doctor? I just want to make sure I'm in the right room. Okay, now let me narrow that down. How many of you have ever left a doctor's appointment thinking, did the doctor really listen to anything I said? Or have you gone to an appointment with a list of questions, whether they were in your head or written down, and really didn't get a chance to ask? Everybody hear me okay?
No, I can't.
Yeah, you really have to. That's why we have the mic here, because we have some
Okay. Can you hear me now? A little bit better? I'll try to talk a little
You
longer.
really need to be very close to the mic.
Gotcha, okay.
So move the mic closer to you so you don't have to bend.
I wasn't sure if this was working. Okay, how's that? Okay, I'm going to start over with that segment. So if you've ever been to a doctor and you've had a list of questions that you wanted to ask, whether, like I said, if they were written down or just in your head, and you found that when you left, it raised more questions than answers. And I know we've all been there. Myself, I've always taken a list of questions and found that maybe some of them were answers or maybe they weren't quite heard. But I know there's another question. How many of you have perfected the art of sitting on that paper-covered exam table, pretending it's comfortable while staring at a poster on the wall that you've already memorized while waiting for that doctor to come in? Definitely. Just those moments, it's like, oh, how long is this going to take? And you just keep looking at that poster over and over and over again. But the fact that you raised your hands right now means you're exactly who this story is for. Because all of us here today have spent years in exam rooms, not as a clinician, but as a patient, watching medicine from that paper-covered exam table and trying to participate in your own medical care. And that perspective is what changes everything. Now, as you heard my story, a little bit of background, 37 years as a graphic designer, most of it related to a healthcare setting, whether it was in a medical device or I worked for Press Caney for a number of years, the place that you get all these surveys from, after every appointment. I've had a very active lifestyle. I was a runner for 20 years. I was a cyclist. I was a gym rat. Tried to eat very healthy, never smoker, and never had a lot of serious health issues for most of my life until now. And also a finished carpenter and DIY for many years, working on the home and things like that. But my story did not start with a dramatic collapse or a sudden diagnosis. It started very quietly. As I mentioned, being a runner, I was a member of several run clubs. I ran many 5Ks, 10Ks, half marathons, and a full marathon. And all this started immediately following a half marathon. I was a pacer for the marathon, where I was leading a group of people to finish at a precise time. So I had to alter my pace and my stride to that assigned time frame. So if I was told that we need to finish around 2 hours, I would have to adjust my pace to do that. And then immediately following that half marathon, my IT band in my right knee went, and which is a common overuse injury, most likely from altering my stride. But what I noticed when I was recovering from that IT band, I continued to run a little bit, dealing with it, but I started getting ascending numbness up my foot, my right foot particularly, and it felt like my foot was asleep while running. And I dismissed it like most of us do. It's like something that comes out, oh, maybe it'll go away on its own, but it didn't go away. It persisted. And there was increased weakness and fatigue, things that just really didn't correspond to my 20 years of running and building up for this half marathon. I'd be running, 14 miles on every Saturday, just gearing up for this. So I knew what overuse injuries were. I knew this was not something normal. And I knew ascending numbness in particular wasn't a normal thing. So again, I tried to ignore it. I rested, I stretched, between runs. I adjusted where I could and pushed through it. And, it could also be, a symptom of just getting up in age, stress, or just one of those things that comes along. But over time, these symptoms became a lot harder to ignore when they persisted run after run, and then no longer just dealing with during a run, it would be just walking around the house. I noticed my legs are asleep, and it went from just the one foot up the right leg over to the left leg as well, up that leg. My arms, my fingers, everything were going numb on me. So I began seeing specialists, and then more specialists, and then tests and scans and labs, and nobody really knew what this was. And it was coupled by shortness of breath and dizziness, where I thought I was going to pass out at times, and you had this sensation where you felt this almost whoosh sensation come up from your legs and go up through your head, and it made you almost white as a sheet and almost like you were going to fall over. And this was happening more and more. And often the conclusion was always the same, with these tests and labs and scans, everything looks normal. Now, on the surface, that sounds very reassuring. When your body is clearly failing you, you know your own body, and you know something's wrong. Now, when all that is happening and you're told everything looks normal, normal can feel terrifying, because if everything's normal, then what is wrong with you? And that's what I got a lot from different specialists. The moment of when uncertainty grew into my years-long search for answers, that was that moment when I'd be told over and over again, everything looks normal. Now, this story of mine is not just about illness and rare disease. It's about persistence, self-advocacy, finding hope when the system does not have an easy answer. And this was the reality of navigating a medical system that was fragmented into silos, when doctors just do not talk to one another. And I found that over and over and over again, where I'd be referred specifically from one doctor to another because what they found really branched into another specialization. Whether it was pulmonology, oh, your pulmonology needs to do it with neurology, or your hematologist wants you to go on to somebody else. But the referring physician in some cases just didn't talk to the other doctor. So I'd have to basically start from scratch and describe everything, and none of these silos just seemed equipped to see the whole picture of me. They only saw their part of it, and that was really it. What I really didn't need is another specialist that only saw one part of me. I needed somebody that saw the whole picture, try to put the whole puzzle together. And that just doesn't happen anymore, as far as my experience. Now, in this book, I refer to something called the diagnostic wilderness. What that is, it's the space of knowing something is wrong and being able to prove it. Like I said, you know your own body. You know something is wrong, but how do you convey that to somebody as far as relaying your experience? Now, in that wilderness, symptoms don't generally line up very neatly. Tests come back inconclusive. Specialists only see their piece of the puzzle, and patients are left holding the whole picture. I was told variations of, that's unusual, that doesn't quite fit, let's watch and wait. Or they would probably just look at you with the expression that this is all in your head, or that you're exaggerating your symptoms. For example, as a person, like I said, with 20 years of running, one of the most persistent and frustrating disconnects in this has been around that muscle strength testing, which is basically called the confrontational muscle strength, where you go to the doctor, they push against you, pull, it's like push against my hands, move, push your legs against my hand, things like that. Time and time again, when I was particularly declining, where I could barely get up out of a chair or walk up a flight of steps, even by the time I hit the second step, I was fatigued, my legs felt like they were this large, I can barely make it to the top of the steps, I couldn't run anymore. But then the doctor would say, after that strength examination, which they didn't do quite right, where they flew through it, they don't take into account fatigue and resistance and things like that. You were told that your strength was normal, that your muscles are strong. Now, when you're a runner, when you're fit and when you're active, there's different baselines. My baseline was a little different because I was very strong in aspects where I can run very long distance, I can go to the gym, I can bicycle for 20 miles, things like that. But when you're told your muscles are strong, when you can barely hold a book for more than a few minutes at a time and your hands are dropping it, or you can barely walk up a flight of steps. I was using a cane last year. I struggled to walk my dog. But time and time again, you're told that. Now, that frustration that I was strong, like I said, when I can barely do this, climbing a flight of steps was like summiting Everest. It's just not a communication gap. It's a fundamental flaw in the exam itself. There's a lot of times where you're told to give objective evidence of this, whether it's showing a pulmonary function test of this decline or things like that. But when a doctor does that, I have found when they say your muscles are strong and that disconnect is there, it really is kind of a flaw in that exam. It's highly subjective. And if it's not done correctly, it really doesn't match your reality. You know your reality. You know that there's functional decline. So how are you weak? How are you strong when you know you're weak, or you're not as strong as you used to be? That's where I'm at. My legs would buckle. I could barely button shirts. My arms felt heavy. I could barely sustain any kind of activity without being exhausted. So being told what you're experiencing is not as severe as they perceived it to be, or it's normal, or the feeling of being doubted, of having your lived experience discounted, is almost debilitating as the symptoms themselves. And here's the thing about waiting until symptoms do line up neatly, or when tests finally do come back conclusive. You know your body, you know when something's seriously wrong, you're losing strength, you're losing mobility and function. Waiting has consequences. For me, worsening symptoms, delayed care, and treatments. I had to push so severely to get treated for this because I knew waiting had those consequences. Everything is getting worse, and sometimes you go beyond the point of no return. When your function, and like me losing muscle, that muscle is not coming back. You know, I was getting atrophy in my legs, in my arms, in my neck. And then I really slowly realized something very uncomfortable. If I did not become an active participant in my care, I may never get the answers and treatment until it's too late. Now, I didn't set out to become a researcher or advocate, but necessity has a way of changing people. I began doing this in 3 different ways that really changed everything. First thing I did is I started documenting everything. Not just test results, but patterns. When symptoms worsened, what made them better or worse, how they affected my daily life. So doctors see snapshots, patients live the whole picture, and that context really matters. So what I did first is I just simply began keeping a diary. After the symptoms I originally dismissed, hoping they would resolve on their own, they persisted, worsened, and became more constant. I kept that diary describing precisely what I was experiencing. This eventually expanded to keeping a history of my symptoms, noting onset dates, the specific doctors I had seen for each issue, any tests or procedures performed, my current medications, and a running list of notes or questions to address with my doctors. The second thing, I learned to research responsibly. And a key part of that process was understanding the terminology. I imported every test result, blood work, imaging, collected every clinical note from every doctor. I wanted to understand each possible disease in depth and its symptoms, risk factors, diagnostic tests, and treatments, no matter how unlikely it seemed. As long as it might explain what was happening with me and the worsening of my condition. If a result was abnormal, I wanted to know what it meant. If it was normal, but my symptoms persisted, I explored why a standard test might miss an atypical presentation. I then immersed myself in very credible evidence-based literature, like peer-reviewed journal articles, white papers, case studies from the National Institute of Health, resources like, say, from the Mayo Clinic, Cleveland Clinic, Johns Hopkins, Columbia. I deliberately avoided things like Wikipedia or WebMD or personal blogs and online forums. I did not want to get the stigma of Dr. Google. I really did not want that. Now, knowledge did not replace my doctors. It allowed me to partner with them. Now, the third thing I learned was how to speak up, calmly, clearly, and respectfully. That was the hardest part. Advocacy doesn't mean confrontation. It means saying things like, help me understand why this doesn't fit, or what diagnoses are we ruling out, or what would explain all these symptoms together. And sometimes I know this is atypical, but I need you to look again. Advocacy, whether self-driven, professional, or community-based, is what ensures your voice cuts through the noise for a system built for textbook cases. Now, along the way, something important also happened. I did find clinicians that actually listened, like my primary care physician, my pulmonologist, my hematologist, urologist, cardiologist, consistently demonstrated a genuine willingness to listen. They acknowledged my concerns, praised my self-efficacy, and were open to exploring tests or referrals suggested. Their empathy created a space where I felt seen, heard, and genuinely supported. They acknowledged, this is complex. You're not imagining this, and let's think differently. These moments were really, truly transformative, because being seen, truly seen, restores hope in ways medicine alone cannot. Now, unfortunately, other experiences have largely been the study in contrast. I felt they only hear what aligns with their rigid adherence to textbook criteria, or bias towards more common diagnosis, exhibiting a profound lack of empathy for your lived reality. It is in these interactions where doubt does creep in. The unspoken suggestion that it's all in your head. This dismissive attitude erodes the most fundamental element of patient-doctor dynamic, which is trust. I often felt feeling invisible, as if my suffering had been politely noted, but not truly heard or believed. And that's really what this title is about, that unseen illness. If you feel invisible, feel that you have been dismissed, and this has happened more times than I can tell you over the last 3 years. It reminded me that a system, while I may struggle with the atypical, people within that system still matter deeply. Now, why I wrote this book. I wrote this book as a means of coping with this disease, of years worth of research into every aspect of what this could be. Now, I didn't write this book because my journey was unique. I wrote it because it wasn't. It has been my attempt to give voice to the experiences of living with an undiagnosed or misdiagnosed illness, or navigating a healthcare system that was never designed with patients like me in mind. Now, as I bring this to a close, I want to look forward towards change that needs to happen in how medical professionals are trained, how we define expertise, and how we treat people who do not fit that mold or that textbook case. I don't know how many of you, have been to a doctor and they just don't know what this is. And sometimes you'll get that diagnosis of exclusion, or that's been my case. And it's happening more too often that I care to really talk about, where it's so atypical. In my case, I'm a 1 in 2 million rarity. I have a very rare presentation of an extremely rare disease. So I get it. It's not easy for doctors to diagnose. So the first thing they do is look at textbook presentation, and they'll do gold standard tests and a whole battery of tests. And when they don't get those clear answers, even though your symptoms present in such a way, or if they're not truly listening to you, which is one of the first things a doctor should do, just really listen to you, especially if you don't fit that textbook, whether it's a muscle biopsy or an MRI, that you've gotten back, or a lab result that doesn't quite make sense. We need to try to fit, like I said, those people that don't fit the mold equally with those that do. Because too many people fall through the diagnostic cracks. You feel dismissed. You start trusting yourselves. Now, this book, as I said, is for patients that don't fit that textbook, families that watch someone struggle, providers who want to listen better, and anyone who believes healthcare should be more humane. The final chapters of this book, how we think about diagnosis, breaking down those silos, having doctors try to talk to one another more. And every doctor I see, I ask very politely if they can pass on their clinical notes to the doctor that they need to go to, that, say, a pulmonologist, how those pulmonology results reflect my restrictive lung disease, which is started all from my neuromuscular disease. Can you please pass those notes to my neurologist? Or if something doesn't line up with my ear, nose, and throat doctor, that, well, this seems like it's an inflammatory disorder, this, this kind of goes along with your can you please send those notes to my neurologist? And more often than not, I would ask my neurologist, did you ever read the notes from that doctor? Or I would carry in a test result from that doctor, and they either didn't read it or would never read it, as I found out through further clinical notes that just nothing was in there. So in closing, if there's anything I hope you can take away from this today is, you know your own body. Your experience or your family's experience going through this is very valid. And asking to be heard is not asking too much. Whether you're navigating illness for yourself, or, like I said, advocating for someone you love, or simply listening more closely, your voice really matters. So again, thank you for listening. Thank you for really coming here to hear me about this. And thank you for allowing me to share my story with you. Oh, definitely questions.
So, may I ask what eventually was diagnosed with you, or you don't?
Well,
want to?
as of
It has
yesterday,
implications,
yeah,
I don't
I'm
know,
still
all
on.
that you're talking about.
I still am undiagnosed. Can you believe? It seems like I'll go 3 steps forward, 10 steps back. I have enough diagnostic evidence coming from pulmonology, hematology, musculoskeletal, my neuromuscular rehab, and lab work that points to a very, very rare form of dermatomyositis. Because I don't have the telltale rash, because nothing shows up on muscle biopsies, but I have a very, very specific antibody it's what's called an MSA, a myositis-specific antibody. It points to a very specific form of disease, and that antibody is one of the rarest. It's the most hard to detect, and it doesn't follow the same rules as other forms of this disease. So that's why I was saying it's a very rare atypical presentation, because the normal test that you would get would be a muscle biopsy or an MRI or an EKG, a nerve conduction study, things that in certain labs that will point to muscle inflammation and things like that. My muscle inflammation fluctuated, which it can do. A muscle biopsy was non-diagnostic, which it can be in this form. It's not going to show in muscle because my muscle disease is not going to show in muscle fibers. Mine happens to be subvascular. So there's inflammation throughout my whole body, but it's not the type that's going to show up in an MRI, so it's mostly invisible. So that myositis-specific antibody has been positive 3 times. It's very, very hard to detect, first of all. The fact that it was detected 3 separate times for one of the ones that's most hard to detect kind of proves there was enough of that antibody in my system to detect it those 3 times. The doctor that I'm going to be seeing on Friday is one of the best in the country. He's out of Johns Hopkins. He's also a top researcher at NIH. He is one of the best in the country for atypical disease. In his white papers, he discusses that only about 50% or less of people with this form of disease have something that's going to show up in an MRI, less than 50%. And if you have the antibody that I have, and muscle biopsy is not even necessary. That antibody is so diagnostic in itself, along with the symptoms that clearly match it, along with the restrictive lung disease that I have, and the response from the infusions I get, are more than enough to be diagnostic.
So you did not have a battery of tests to rule out autoimmune disease early on in your diagnostic evaluation?
It took a long time to get there. Right now, just last week.
I don't know how specific is this antibody, but generally someone with your symptoms, one of the early things that the doctor would do is a battery of tests for autoimmune disease. And the autoimmune disease, there are certain entities that are really specific for arthritis,
Yep.
problematitis, but there are a lot of syndromes that are big, they're overlapping,
Yes.
and variant and so on. And it shouldn't be surprising to you that the average doctor, specialist, and subspecialist, even someone who specializes in rheumatology and autoimmune diseases may not hit on your diagnosis right away. But surprisingly, there is a test that you're telling me, and I'm not, I'm
Yes.
a retired doctor, but not in the field, that is really specific to your specific, that wasn't done, especially since it's a blood test, it's not an MRI, it probably
Right.
doesn't cost 10% of the cost of MRI. So that would be failure. But to expect that in any average doctor, whether the family physician or specialist and so on, that will hit on this very rare. We are taught, and it's rightfully so, that to consider the common condition first.
Yes.
Because what's common is common. Doctors should not consider brain tumor on every patient that walks in complaining of headache for 3 days, and so on. But yes, you have to consider it in the right circumstances. So a lot of what you described are very legitimate. I practiced medicine 45 years, and I've seen this a lot. But if you expect that every doctor that you walk in is going to spend 5 hours with you, review, especially if you come after a big pile of tests and letters from every specialist that he's going to have, he may tell you, look, if you want me to go over all this, I may have to charge you for 3 patients. and it's legitimate. There is when I have my schedule in the office, if it's a new patient, I have 40 minutes or an hour. And sometimes I spend more than that if I feel necessary. But to expect that, oh, you should talk to the other doctors, but don't waste my time for me to repeat all my story is first, even if I read everything about you from another, I want to hear from the horse mouth. I want to examine the patient myself. I don't rely on that and so on. And so anyway.
Yeah, I mean, believe me, we went through all the basic stuff first. We tried to rule out as many things as possible. I mean, things like MS and even ALS came up and these came up from other doctors, and so we had to rule out each thing. And we did a number of, EKGs, and we went through tons of labs. And the myositis test, they did the whole panel 3 separate times. In conjunction with CKs, and try to rule out as many things as possible straight on. I mean, I went to rheumatology that thought, well, and thought that maybe this was fibromyalgia because I do have osteoarthritis, and they tried to rule out rheumatoid arthritis. And, you know, it was a lot of simple things at first, or musculoskeletal. I did have a tumor in my spine that came out from doing all these tests and things that, okay, well, maybe my symptoms are coming from that. It was found arbitrarily. It turned out to be benign, thank goodness. I did not have cancer, but that had to be ruled out. Or a fistula in your spine that could cause numbness. So we tried to figure out the ascending numbness thing first. But then it came to be more muscular in nature, where it would be affecting, you know, my quads and, you know, the things that you would do, like walking up a flight of steps. Okay, it's going to affect here and here. And, you know, certain tests did say, okay, there's a problem with the ulnar nerve, and maybe one of the reasons my hands are getting weaker and weaker. But, and we did so many different labs and tried to rule out as many things as possible. And then when this myositis-specific antibody came out, it's highly, highly specific. So it points to only one form of disease. There's dermatomyositis, there's inclusion body myositis, there's polymyositis, there's different forms. And this one over and over and over again pointed to dermatomyositis. Now, most people with that disease, again, it's rare in itself, and there's different antibodies that can point to dermatomyositis, not just the one I have. One I have is one of the more uncommon, one of the most rare. So there's others that will give a very clear answer. So those patients will either show up with the Shaw rash, it's usually, or Groton's papules, or they will show something within the muscle biopsy. And it's slam dunk. It's like, okay, you have this, so we know what it is. But in cases like mine, and I've had to go from one institution to another that dealt with more of this. I went down to the Mayo Clinic. They weren't aware of this type. There's certain types of these antibodies that have been out a lot longer than others. Back in 2017, they opened this panel of antibodies out. The first one out, been out the longest, the most research, was the Jo1 antibody. That's the most common. A lot of doctors are very familiar with that particular one. Mine, there's not enough information about, and they don't understand how it affects different people. Like my current neurologist is not aware of how this may not show up in muscle biopsies because it's not fibrotic. There's no necrosis of that. With the form I have, what we learned through other labs, they did something called the von Willebrand factor testing on me, which came back high. Also, they did a cytokine panel on me, which came back high. And it did a platelet aggregation study, which all came back high. Now, all three of those together shows that I have systemic inflammation going on throughout my body. And they tie directly to dermatomyositis. What it means is there's endothelial activation going on, there's, which makes you feel fatigued and things like that. It gives symptoms on their own. So this keeps evolving. My pulmonologist saw that, okay, I had shortness of breath as a runner. So we figured that out. And it doesn't mean that there was something with my lungs. There's something with the muscles around my lungs causing me to be short of breath. So I'm working with 10 different specialists right now and trying to piece all this together pretty much myself.
Did they, in the early workup, just one, did anyone suggested a therapeutic trial? I mean, this is very practical.
Yeah. I did trials of corticosteroids. Over the years with my spinal issues, they did spinal injections with steroids. They never worked for me. And with my current neurologist, last December of 2024, they did a 40 milligram per day prednisone trial for 4 weeks. Didn't work with me. So I'm refractory to steroids. So I can't do steroids. So what I'm on right now is intravenous immunoglobulin. There's a lot of, for dermatomyositis, there's first-line treatments. Prednisone is number one. If you're not tolerant to prednisone, which I am not, it doesn't work. So there's immunosuppressants or steroid-sparing treatments like methotrexate and MMF and azathioprine or IVIG. Now, when I went into the doctor, I did a side-by-side comparison of all these things. Now, because I have hematologic issues, my neutrophils, everything are through the floor, some of these will cause bone marrow suppression. Some of these will bottom out your cells even further. So they were like, do not go there. So IVIG has been the safest option, but it's not a lifelong treatment because it's one of those things that cause things themselves. Like right now, I am immunocompromised. After I go for IVIG, which I do every 3 weeks, 2 days every 3 weeks, it causes my neutrophils and white cells and hemoglobin and red cells to fall. And right now, I am on the borderline of moderately to severely compromised. My neutrophils are 0.5.
Why giving you immunoglobulin suppress?
Well, what it does is the side effect was it pretty much affected my immune system in a negative way. But that can happen, but they didn't expect it to happen that much. But what it did is my shortness of breath, my pulmonary issues where I was severe as far as my inspiratory and expiratory pressure went from severe to normal after I started doing this treatment. Also my muscle function where I could barely walk up a flight of steps or run anymore. I went from not being able to run for over a year to starting to run again. So that's what it's done for me. But now there's other factors, contributing now where I need to go, they're going to do a corticosteroid part of my infusion administered in a different way, not as trying to fix, not really as therapeutic, but really to reduce my, or improve my, I should say, improve my neutrophil issue, that being immunocompromised. Because the theory is by giving me that prednisone in conjunction, it's going to raise my levels and not make me so compromised. So, but, oh, I'm sorry.
Thank you for your talk. Really, really well done. I'm a family physician retired and I practiced for over 40 years. I can appreciate what you're saying, and I feel for all that you've had to go through. But I think you raised a lot of important points. Firstly, that your physician should listen to you. And I made a point over my years of practice that your patient is actually your partner in healthcare. So and getting to know your patient, when things are not what they're describing is not what their normal function is. So you made it clear that the symptoms that you're having is not normal for you, and having a doctor that listens to you is obviously very important. And the other thing I found as a family physician, and I would spend many hours, nights and weekends reviewing everybody's information. So you can get very lost in going from one specialist to another, and and as you say, doctors not talking to each other. So that's where I found as a family physician, I was like the accumulator of all the information. And I was the one that really could put everything together, looking at what everybody's saying about it.
My family doctor is much like yourself. He is absolutely wonderful. He does everything in his power to help me in whatever means necessary, referrals and, whatever he can do. So I totally get it. And my wife is a physician assistant, has been so since '91. She's about to retire this year, and she works for the VA. So she gets it too. There's so many patients that she sees, and sometimes it's hard to come out of that silo and talk to, other providers. So I definitely get it, but this, listening is so important, for a doctor, and trying to see, like I said, that whole picture of somebody, especially, somebody that doesn't present normally, this is, wow, you're a runner for 30 years, you can't run or 20 years, you can't run anymore, and you can barely walk up a flight of steps. Well, why would you say, your muscles are normal? It's, pushing against you. Okay, you can do that for a second or two.
Right, exactly.
But
It's the temporal issue here.
Right.
that
Let's
you're just being
repeat.
at a moment in time.
Yeah, let's repeat that so many times. Or, okay, yeah, I can walk up 1 or 2 steps, but 3, 4, 5, 6 steps. By the time when I was going to physical therapy, I had to go up at Body Zone, I had to go up 2 flights of steps. When I was up to the top of that second flight of steps, I was holding onto the railing, I was dizzy, my heart was racing, my legs felt like they were going to buckle any second. And, this is what you're dealing with. I know what strong used to be, like I said. It's just, and it's not that I want this on myself. I want to have quality of life like we all do, and I want to get back to what it was before, when I enjoyed the things that I'd like to do. I would love to run again, and I'm just starting out now. One of the things my doctor said to me yesterday, which is really concerning, because he's the one that, kept repeating the function, oh, your muscles are strong, your muscles are strong. He actually said to me, maybe we should wean you off IVIG so your symptoms can worsen, so maybe we see how this presents differently. Because and I told him, okay, what about this myositis-specific antibody positive? Well, maybe it's cross-reactive. Maybe something in your blood caused it, which is basically almost impossible. Not that anything is impossible in medicine, but he tried to really dismiss absolutely everything. And he basically said, because you don't have anything showing up in your muscle biopsy, I don't believe that this is what you have. Even though I had so much evidence to say the contrary, and I even gave him that article, the one that said less than 50% of patients actually show something on the biopsy and how that antibody is enough for diagnosis. He only believed what he wanted to believe. And my wife went with me. She tried to speak up for me. Said, this is not my husband. This is, we were runners together. I would talk to her during a run. And I would describe to her exactly what I was feeling at that moment in time, only because I wanted somebody to hear what I'm going through, and also so I could recall it for that diary that I talked about, so I can journal all this. Okay, what exactly did I say during that run? I wanted to make sure it was exactly right, and not to, make my symptoms any more than what they were. But like I said, your own body, and things are changing, and that numbness isn't right, but let's dismiss it for now. And then, but when you can no longer dismiss something,
Why are you still going to this guy?
honestly,
What specialty is he?
well,
Have you considered somebody else?
oh yeah, believe me, I've considered somebody else. And prior to this appointment yesterday, I thought we were heading in that direction, honestly. I thought we were getting there. And yesterday, something changed where, I had all this evidence from all the tests, all these abnormal tests that came from hematology just in the last couple of weeks. So I wanted to give him that data, which corresponded to this neuromuscular. It actually gave more answers to what I was going through. And I thought it would really help him out a lot. Say, hey, there's inflammation going on through my body. These CK levels are fluctuating, they're mildly abnormal, but here's something that really truly shows ongoing disease state, ongoing inflammation in my body, and how it relates to this disease. I gave him 3 or 4 white papers, how they correspond to dermatomyositis. And he dismissed everything. And he was almost argumentative, where
What specialty?
specialty?
neurology. He was in,
Neurology?
he was,
This isn't working
This is
out.
not the specialty you need.
well,
No,
yeah,
honestly.
well, I mean, he was,
Once, and you seem to believe that your problem is this rare form of dermatomyositis, you stick with the immunologist, someone that is.
oh, I get it. I mean, he specializes in ALS, he specializes in neuromuscular disease. Yeah.
That's
Well,
the one
well,
that should
you know,
be.
There's so much data out there in the world today.
Yes.
And somebody needs to be very clever about how to get information out of the data. I was listening to a tale of testing for rare diseases in embryos. And well, you know, each disease on its own is rare, but if you put together all the rare diseases, you have a lot of people that could be affected. And there must be a way to mine data.
That's
and
AI. That's
AI.
AI,
No,
AI, honestly,
I
you're
mean,
right
it
on.
would be very helpful
The
in
combination,
medicine.
but we can't expect every simple
No.
person, of course, to know everything.
Right.
But they need to know how to tap into resources.
What has been the response of your health insurance company, like paying for MRIs and things like that? I mean, have you had to,
Yes.
if you don't have a specific diagnosis, there's an ICD-10 code and a
Yes.
CPT code that goes with that.
Yes.
Right.
and you
I
have to
actually,
get notes
after going through 10 rounds of IVIG, and each round was approximately $10,000 to $11,000 for every, and each of those rounds was 2 days. So you're talking about 20 different infusions times $10,000 to $11,000 each. After going through that, and you know, the insurance was contacted first. There was the approval, things like that. I actually got a denial letter because the doctor didn't put through the medical necessity of those things. So eventually it was fixed, you know, because there was medical necessity for it. But it became, and I was supposed to go to IVIG again the following week. But at that moment in time, I was holding the bag for $120,000 worth of infusions that were done. So I was like, I need you to figure this out now, because am I supposed to go next week knowing that I'd have another $20,000 to add on to this? So yeah, and the thing he did again yesterday, he brought up, and he continues to do this, is diagnosis of exclusion. I mentioned fibromyalgia, but there's also chronic fatigue syndrome. And because I had a spinal surgery years ago for that tumor, they said I could possibly have arachnoiditis. Now, arachnoiditis is a nerve root disease, it's nerve pain of the spine. I don't have shooting pain. All my stuff is muscular. So I don't have shooting pain going down my legs. I don't have chronic fatigue syndrome because I'm energized. I was energized, you know, after running, and right now I'm starting to run again very slowly. I feel so energized in the morning. Chronic fatigue syndrome doesn't act that way. And also, it does not respond to IVIG. And it doesn't have all these symptoms and presentations, and it's not going to have a myositis-specific antibody that points to dermatomyositis. It's not going to have so how are you going to justify IVI treatment for a diagnosis of exclusion that does not respond to IVIG, that does not have a myositis? Why are you saying this? It's because they don't have an answer, so the fallback is on to something that clearly doesn't fit you, rather than giving me a diagnosis that clearly does, but you're resistant to give that diagnosis because you don't have the muscle biopsy. And that's the only thing that he's waiting on. Ma'am.
How long you been going through this? How long-
Oh, it was started October of 2022. So I went at the end of October 22 is when I finished that half marathon, and it started immediately following that. And I've been battling this every single day ever since.
Has
And
anyone sent you to a university teaching hospital?
yes,
So you've done that already?
I've been to, well, I started locally, and then I went to Hershey. After Hershey, I came back here, and then I went to Penn. And then I went from Penn to Mayo Clinic, and then back here again because there's not a lot of other people. My hematologist actually recommended the current one I'm seeing. Mistake. But on Friday, I'm going to Johns Hopkins down in Baltimore, and the guy there is one of the top researchers in the country. He not only formed the myositis clinic with Johns Hopkins, he's also a top researcher with the National Institute of Health for neuromuscular, musculoskeletal, and rheumatology. He understands rare atypical disease. That is his bread and butter. A lot of the research papers I read were his, or he is referenced in other papers. He knows this. He's the one that said about not needing a muscle biopsy if you have this antibody. That's the person I really need to see. Thank you.
I'm sure that Michael, if he's available, would be able to stick around. I'm going to be the timekeeper right now, but Michael, if there are more
Yeah.
questions.
Sure.
After we wrap up.
Yeah.
But if we could have another round of applause for Michael Stanislaw.
Thank you. Thank you.
And we certainly hope that you arrive at some sort of diagnosis that is going to help